Do you want me to share now السكرين ولا لسه؟
ممكن تنتظريني دكتورة شوية؟ دكتور علي, if you want to start, it's 9 sharp.
يلا. بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. I would like here to welcome all our attendees as we are launching our single topic webinar series today. We welcome everybody, and we have an interesting topics on a monthly basis. We will start with cystic fibrosis, which is a topic, an important topic rarely discussed in meetings and webinars, and we have the pleasure to have eminent speakers. First speaker is Professor Hannah Banjar. She is professor at Al Faisal University as a consultant pediatric pulmonologist with an experience of more than 30 years. She is one of the figures of cystic fibrosis in the region, and she has a basic research in cystic fibrosis, and she published many publications in this regard with the local data, and she has established a cystic fibrosis registry at King Faisal Specialist Hospital and Research Center. Today, she will talk about the status of cystic fibrosis in Saudi Arabia. Professor Hannah, please, you are more than welcome.
Thank you very much. Assalamu alaikum wa rahmatullah. Good evening, everyone. So I'm gonna start sharing my slides. So I will talk about cystic fibrosis. Just a minute. Okay. The objective of today is initially very quickly talk about the pathophysiology, and then an update in general in cystic fibrosis, and then about our data. Okay, so you know the cystic fibrosis is the most common autosomal recessive disease leading to a decreased lifespan in Caucasian, with an incidence of 1 in 2,500 and 3 to 4 carrier rate in United States. The median survival has been improving since the initiation of cystic fibrosis center in the rest of the world. The discovery of cystic fibrosis started in Lebanon in 1958. That's in the Middle East, then followed by Iraq, and in Saudi Arabia it was described in 1985 with an estimated incidence of 1 in 4,000 live births. We know that cystic fibrosis is mainly, the defect is through the gene called as a CFTR gene, or the cystic fibrosis transmembrane regulator gene. And it's really a very big gene, is a 27 exon, and span for a protein that is 1,480 amino acid. I know I started by the gene because it's now everybody is talking about the genetic basis of all diseases. So you can imagine if you have 1,480 amino acid, the chance of deleting or substituting one amino acid or 2 or 3, whatever, up to 1,480 is really tremendous and infinity almost for having mutation in this disease. So up to now, there is around 2,000 mutations described in the whole world. Briefly, it's due to, the CFTR protein is situated in the apical membrane of airway epithelium and also in the GI epithelium. So the main function is really to shift the chloride from intracellular into the lumen. Water follows the chloride, so that's why the secretion is normal. Whereas in cystic fibrosis, because of the defect in this CFTR protein, the chloride will remain inside the cell. The water will follow, so that's why the secretion will be very thick, like a gum, inside the bowel and also in the airway. So this is the main pathology for cystic fibrosis, and this is why it was called the mucoviscidosis to start with. Whereas in the sweat gland, it's the opposite. So mainly the water, the chloride will go into the lumen of the sweat gland because it is convoluted, and the CFTR protein is situated in the basal membrane, not in the apical membrane. And that's why the loss of the chloride will be in the sweat gland, and the water will follow. There is a loss of chloride and water, especially during the summertime, and this is the main diagnostic criteria is the sweat chloride test. So, but cystic fibrosis affect almost every organ in the body. So due to the airway, the secretion will be thick, there will be infection, destruction, pulmonary fibrosis, pulmonary failure, and so on. And it's really 95% of patients, they die from infection. So this is why pulmonologists are involved mainly here. Because of the thick secretion, there will be meconium ileus early in life, intestinal obstruction, obstruction of the pancreatic duct is called mild digestion, malabsorption, failure to thrive, and in the bile duct is focal liver cirrhosis. In the cervix of the female, there will be the thick secretion, so there will be decreased female fertility almost to 75%, whereas in males is due to absence of vas difference. In 98% will be infertile, and of course the loss of chloride will cause the dehydration. So starting our data, we will talk about the demographic data of our center from our registry. We have around 430 patients. On an average, we diagnose 20 patients per year, newly diagnosed. So we have a total of 430 patients in the registry. 90% are alive, 10% have died. Age at diagnosis at 4 years, plus or minus standard deviation of 6 years, and age at follow-up 6 plus 5.39 years. Male and female ratio are the same. The eastern region are the main referral, almost in 36%. So almost 1/3 of our patients are from the eastern province, and then follows the western province, the central, and so on. Despite the western province have King Faisal in Jeddah, we still, some of these patients are referred. But mentioning this, actually, King Faisal Jeddah are involved in our registry here. Consanguinity is very high. You can see almost not related in 16%. So that means almost 80% of our cystic fibrosis population are related somehow, either first cousins or, other relation. And the family history, or almost in 50% of them, they have family history. Some of these families may have 1 up to 7. We have families that they have 7 cystic fibrosis patients. So you can see how much the consanguinity contribute to this disease. Talking about genotype, which is really, the main thing that is really different in the rest of the world. Our genetic mutation is really different. We know that in the Western North America and Western Europe, delta F508 is very common. Almost 75 to 85% of the mutation are caused by the delta F508. But in our country, or almost on the Gulf and in the Middle East, is totally different. So the difference here, this is the delta F508, which is here is the new nomenclature. All these, the new nomenclature that is proposed by the genetic consortium of the whole world, that they register all mutations. You can see in the right, the percentage of these affected alleles and families is only 11%. So the delta F8, which is common in the Western world, is only 11% in Saudi Arabia, the same in the Gulf area, whereas we have different mutations that are common and actually newly described. So our mutations are really specific to the Gulf, that is not described before in the medical literature. We describe almost five new mutations, but they are common mutations in Saudi Arabia, which is mentioned here. You can see the common mutation is called the C14-18 deletion G, the first one here, and it consists of 17%. So you can see in the list here, the 10 most common mutations in Saudi Arabia that constitute 80% of our population. And it is unique. We don't have one single mutation. Even the most common mutation is only 17%, not like North America, 75 to 85%. And why is that? Because again, the tribes, you know, they intermarry each other, consanguinity is very high. So they maintain their mutation in the tribe. For example, Al-Enzy is different than Al-Mutayri and so on. So and I think it also consider that the same as in other genetic disease mutation. And you can see the common mutation, 95% of that population in that mutation are really homozygous. So you can see almost 95% to 98% are homozygous state of the genetic mutation. You can see here another 30 problem mutation, and each family has their own mutation. So, you know, we don't have really that much common mutation in Saudi Arabia. Almost each tribe has their own mutation. We also, I mean, in this publication, we mentioned another new mutation. Here we have mentioned 5 mutations. Geographic distribution of the mutation itself, you can see the Eastern province. Here it's written the East, 37% of our population. And the most common mutation is really the most common mutation that is described in our population. So the Eastern province and actually Riyadh area have the most common mutation that is described in Saudi Arabia. Again, we have very unique mutation in our population. We describe double homozygous. What it means that to have cystic fibrosis, you have to have a mutation in each allele. We have 2 alleles in each chromosome. But in this population, and what I'm going to describe, you have 2 mutations in each allele. That means there are 4 mutations in this population, which is really interesting. This is, you know, the second case described in the whole world. The first was described after tremendous search, and it was described in 1989, which I'm going to discuss. So we have the second, you know, described homozygous, double homozygous, which means that, as you can see here, this is the one allele that has 2 mutations, one up and one down. So this is one allele has 2 mutations, and the other allele has carbon copy of these 2 mutations. And we really, you know, screened the family and so on, and we found the mother, father, and brother have 2 mutations in one allele and they are considered carrier. And then we really searched the whole literature. We described in our population 4 families, and they are totally different from different cities of Saudi Arabia. And you can see the drawing here that they have 2 mutations in each allele. So this is our review of the whole world literature, and we found only 1 publication that mentioned it from their group. There are many complex mutations that have been described, but not double homozygous. So we really have, the double homozygous is very common in our population, which is really very rarely described in the rest of the world. We come to the bacteria, Pseudomonas, continues to rise with the advancing age. MRSA is also rising, recently. This is in North America, and it started in 2001. Now it's coming like almost 20% of the population has MRSA, which is really, again, is a very bad sign for cystic fibrosis patient. When we studied our population, we found that the Pseudomonas, which is the why do we always stress on Pseudomonas? Because it's a very bad bacteria. Once the patient has it, if you don't treat it within 2 years, these patients die. And this is why we have to screen all these patients and be aggressive in treating these patients, even if they are not symptomatic. And the Pseudomonas continues to rise. In last follow-up, it becomes almost half of the patient, they are colonized with this Pseudomonas bacteria. MRSA, again, rising in Saudi Arabia. It consists around 11% of our population. And it is common in the most common mutation in Saudi Arabia, if we want to relate it to the mutation. Then we come to, to relate it to, does the mutation, do our mutation are severe? Yes, they are severe. Here it shows that the most common mutation in Saudi Arabia, they have very severe pulmonary function test. I'm not going to go in details, but I can tell you that they have a severe deterioration of pulmonary function test with the mutations that we have. Our mutation are really severe. So we come to GI diseases in our population, celiac disease and cystic fibrosis, the association. We have a total here studied 391 patients. All of them, of course, underwent the treatment with pancreatic enzyme. Almost 95, let's say 95% have pancreatic insufficiency. For those patients, when they come with persistent symptom of diarrhea and failure to thrive and so on, we do screening for celiac disease, as we did here in 74 patients, which comes on 19%. You can see the antigliadin is variable, 5.4. This is in IgA. The IgG in 48% is high. The transglutaminase in 2 patients, 2.7%, and anti-endomysian in 4%, and anti-reticulin in 2.7%. For those patients who had severe symptoms, their failure to thrive and so on, we talked to them about the bile biopsy. 12 of the 74% who had persistent symptoms and not improving on our treatment, they agreed to do biopsy. But only, you can see here, the result of the biopsy, only 2 have the typical finding of celiac disease and pathology. As you can see here, the typical finding, you are better than me in reading this biopsy. But it was typical for the celiac disease with flat lesion, a total villus atrophy, and diffuse increase in intraepithelial lymphocytes. We come to vitamin A deficiency due to the fat-soluble vitamin deficiency and the loss because of the pancreatic insufficiency. You can see here the vitamin A, vitamin D, vitamin E, and K. The normal level in the second line, and I put it here. When we took the first sample, it was for vitamin A at age of 8, the standard deviation in the 2 brackets here. And it's the same, more or less the same. We take the same time, the vitamin D, E, and K. Sometimes the K is not available and so on. That's why you see the age is really higher here at 10 years when we took the first sample. The mean, the mean here is the mean of the general population of cystic fibrosis. And you can see even the mean of the general population is deficient. But when we took only the deficient group, that is in red here, in the first sample, we have the first sample, 72% have vitamin A deficiency and 81% vitamin D deficiency, vitamin E in 31%, and vitamin K in 23%. So even from the first sample, we have very high vitamin deficiency, despite these patients have been probably 4 years or 5 years before this measurement, they were on EDX vitamin supplement that is provided, or I mean the same dose guided by the WHO. And this is the level 214 in vitamin A and so on. You can see it in red. All of them are deficient. The last sample, which is the one coming in blue here, you can see the difference in the first and the last sample. There is 4 years in vitamin A and 7 years in vitamin D and K. So there is, you know, a period of 4 to 7 years of taking vitamin supplement, the regular that is, you know, guided by the WHO, but patient continued to be deficient. Like you can see here in red, the last follow-up, in vitamin A, 73% continued to be vitamin A deficient after 4 years. In vitamin D, after 6 years, 81% continued to be deficient. In vitamin E, 18%, and in vitamin K, 36%. So despite really giving continuously the supplement, what is supposed to be sufficient, as said by the WHO, our patient continued to be deficient on all vitamins, even up to 7 years of supplements. Here also the bone marrow densitometry, you can see initially 40% were only normal, so that means 60% were abnormal, either mild, moderate, or severe, and it continued up to almost 30% continued to have bone marrow densitometry deficiency despite the vitamins the supplements. So in conclusion, 23 to 81% of our population continued to have EDX vitamin deficiency despite the supplement. So our recommendation here, it's good that we have done this study, is that we have to double the dose. Basically, from the start, you have to double the dose of what is said by the WHO. So we come to liver disease study. We have like this patient, 10 patients with liver cirrhosis, and we have identified all these mutations. You can see there are certainly common mutations that have liver cirrhosis, and these are really bad mutation and also common mutation in Saudi Arabia. You know, for the increase of liver enzyme almost in 40% have high liver enzyme, but these are the ultrasound finding of the you know, of these patients. You can see the coarse liver cirrhosis in 4% here, and increase echogenicity in 24%, only normal in around 56%. So almost 40% of our patients at presentation, they have abnormal ultrasound of the liver. It goes the same for the liver enzyme, as we mentioned, almost 40% they would have high liver enzyme. For meconium alias, 11% of our population present with meconium alias early in life. Almost 66% require, 35 underwent surgical. So 80% required surgical intervention, and the rest, it improved with gastrografin or N-acetylcysteine. And the mutation, there are common mutation for the meconium alias, as we mentioned here. We also studied the gut microbia and its relation to vitamin D status and pulmonary function test. This is done by King Saud University, a nutrition master degree. And what their hypothesis is that children with cystic are expected to have low vitamin D, altered by gut microbia. And it is hypothesized that a pro-inflammatory effect that further complicates the existing respiratory inflammation. So they took 35% of cystic fibrosis patient and 24 controls. They measured their vitamin D, and they gut microbia composition was assessed using real-time PCR analysis, and they took also pulmonary function test at the same time. So what they found that children with CF significantly have lower vitamin D, which we mentioned. And they have, those who have optimal serum vitamin D level has significantly higher level of bacteroidetes, firmicutes, sorry if I didn't say the name well, but I'm not used to it, with a significant p-value. There was a significant negative correlation between vitamin D and E. coli. The level of firmicutes was found to be significantly higher in mild FEV1. This study confirms that children with cystic significantly have lower vitamin D. Gut microbial composition was found to be associated with serum vitamin D status, in addition to the positive effect of firmicutes, bacteroidetes on pulmonary function test. Such finding encourage studies that target and modify gut microbia to potentially achieve better outcomes in terms of serum vitamin D and respiratory outcome in cystic fibrosis. So these are the gut microbia that was measured, which I'm not going to read it, but it was done. For the growth, almost, I would say, like here, 30% only they were normal in height and weight, but around 60% they have, between mild to moderate malnutrition at presentation. For the fertility, this is just the final part of it. We know cystic fibrosis, as we mentioned, cause infertility, and for these infertile patients, we have 7 affected patients that they seek medical advice for conception. These are cystic fibrosis patients after they got married. 2 of them had successful PGD and in vitro fertilization with intracytoplasmic sperm injection. One of our female patients had twins with no complication. So in summary, our registry is considered a valuable source to help cystic fibrosis care team, as well as researchers learn about new health trends, develop new clinical care practice, as we mentioned in vitamin D, and to design a research as cystic fibrosis clinical trial. In one of the GIs we mentioned, I think we went into a conclusion that we have to screen all cystic fibrosis patients for celiac disease, even if they are symptomatic, because we found from the group that were symptomatic, the incidence was higher than the general population, like 3% compared to the 1.5% in the general population for celiac disease. And these are the co-investigators, Dr. Ibrahim Mugarri, Dr. Sam Al-Haidar, Dr. Imran Nizami, and Dr. Al Maghamsi from Jeddah, who are the co-investigator in our registry. And also we have the people from the biomedical statistic shared. Thank you very much, and I'm open for questions.
Thank you very much, Professor Hana, for an interesting presentation with a lot of data concerning cystic fibrosis in Saudi Arabia. Maybe Dr. Dhafir, if anybody has a question, you can moderate, the verbal question. And they said, while you are doing this, there is one question about, neonatal screening for cystic fibrosis. Is cystic fibrosis part of the neonatal screening in Saudi Arabia?
Well, there is a plan, and we really thought about it long time ago. And it is difficult because not all patients of cystic fibrosis come to us, or anyway, it's not applied for the regular neonatal screening, let's say. But we planned it, and when we planned it, we didn't plan it as the regular people they do the trypsinogen. I forget what's the name of the newborn screening, and it's mainly from the blood, but we are aiming to do nuclear study, the DNA study from the newborn screening, and we did a study actually through KCAST, and we still don't have the final result, but we would like first to identify the incidence and the common mutation really in the newborn, and then we put it into newborn screening. But Dr. Fawzan Al-Qurayh and Dr. Zuhair Rahbini and Dr. Hasnan are really interested to put it into newborn screening, the regular newborn screening.
Good. Dr. Dhafir, is there anybody want to ask a question?
Yes, Dr. Anur, she's raising her hand. The mic is yours, Dr. Anur, if you want to ask. Unmute your mic, please. Dr. Anur? Okay. She's not answering, so you can take another written question, Dr. Ali.
So, Dr. Hana, from the study about microbiota and evidence of beneficial bacteria that will improve the pulmonary function test, would you recommend routinely giving probiotic to these children?
Probiotic has been used for many GI diseases and infection and so on. But routinely, we are not using it. And also the recommendation, not yet to use it, but there are studies coming out that it is beneficial. We didn't start to use it yet in our population.
Okay. Dr. Dhafir?
There is no one verbal questions. There is no raised hand yet.
Okay, if you have no more questions, I would like to thank Professor Hana Banjar for her participation with us and her time. And we will proceed with our second presentation. And I'm very pleased to introduce one of our colleagues and a friend of mine, Dr. Muhammad Hassousa. He is an associate professor of pediatrics and a consultant pediatric gastroenterology and head section of pediatric gastroenterology at National Guard in Jeddah, King Saud bin Abdulaziz University for Health Science. And he is going to talk about malnutrition and malabsorption in cystic fibrosis. Dr. Muhammad, the floor is yours. Tfadal.
Thank you. Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you, Chairman, for this introduction. And thanks for Cystic and for this invitation. I hope you enjoy my title, Malnutrition and Malabsorption of Cystic Fibrosis. So my objective is briefly the pathogenesis of intestinal cystic fibrosis, then overview of malnutrition and malabsorption of cystic fibrosis, then the management of malnutrition and malabsorption of cystic fibrosis. Well, if you see the cystic fibrosis phenotype or GI manifestation is very, very extensive, including hepatobiliary, so Dr. Ali Mehdi will talk about it, including nutritional, including pancreatic, including luminal GI disease, obstructive diseases, motility disorders, dysbiosis, small bacterial growth. So we know that the children with cystic fibrosis will live longer. So we should be ready for this complication. We should be aware about how to interfere with this complication. So in this cartoon, it's explained how the intestinal cystic fibrosis occur. So Prof. did good explanation about the CFTR. So if you see the dysfunction of CFTR, you will have thick mucus. In addition to that, you will have intestinal dysmotilities with low pH. Then you will have bacterial overgrowth leading to inflammatory stimuli, including interleukins, increasing to inflammatory response. Then it will lead to thick mucus and low flow of the bicarb. So the question, why nutrition is very important in cystic fibrosis, especially there are some dietitians attending these lectures. So we know that there is a poor, the poor nutritional status is associated with the worst clinical outcome. And absolutely there is a strong evidence that nutrition has been improved the mortalities. However, early nutrition intervention, it will play a vital role in the pulmonary health. So I have seen different child, big child, more than 10 with cystic fibrosis, with very wasted. So nutrition intervention will be difficult in this child. So this is why early nutrition is very, very important vital role. And absolutely malnutrition can lead to malabsorption, and medical nutrition therapies is a critical component of cystic fibrosis management. So relation of nutrition and lung disease. If you see this circle, malnutrition will lead to the poor lung growth with the functional derangement, unbalanced oxidant and proteolytic insult. So it will lead to chronic infection, it will lead to the pneumonia, meconium block, then chronic cough, then the child become malabsorbed, it will be anorexic with some GI comorbidity, then you will have energy imbalance with the weight loss, then you will have malnutrition, and you will have continue the circle. So absolutely, we need to break any one of these circles, either by the lungs or to improving the absorption or whatever. So there is a role of nutrition in the lung disease. So what the risk factors? If you see malnutrition, the risk factors is 10%, and mainly is decreasing resting energy expenditures. In addition to that, chronic inflammation, especially the lungs, pancreatic insufficiency, cystic fibrosis related diabetes, and behavioral feeding issues, which is very important in risk factors in malnutrition. And if you compare to the malabsorption, it will range up to 10 to 20%, and the same or similar risk factors, including deficiency of pancreatic enzymes, the deficiency of bicarb, and abnormalities of bile salt mucosal defect and dysmotilities. So, summarize malnutrition, that the main cause of that is inadequate intake. Believe me, if the child has lung problems with cystic fibrosis, absolutely will be anorexic. In addition to that, you have gastroesophageal reflux. In addition to that, low-fat diet. Another one is increasing energy expenditures, including gland disease. Female, we found that female, they have increasing gland expenditure, and I don't know what the cause, and maldigestion with the exocrine pancreatic insufficiency and intestinal disease, and some gene defect and psychosocial defect that affect malnutrition. So what's the definition of nutrition status in cystic fibrosis? So this is one help to our dietitian that in the first 2 years, the child will be at high risk if the weight for height is around 10 to 25%, while you can define nutritional failure if the child has height percentile less than 5 or weight for height length less than 10th or ideal body weight less than 90%. However, more than 2 years, almost similar, but you can including the BMI usually if less than 10%, or if the ideal body weight less than 90%, this is nutritional failure. So we know that sweat chloride is very important testing in cystic fibrosis. However, cystic fibrosis or sweat chloride in malnutrition will be useless. Why? If you have malnutrition, you may have false positive and false negative. So we should be careful especially for pediatrician, if you want to screen cystic fibrosis for while the child is malnourished, it will mislead. So I prefer to do trypsinogen or gene assay or Middle East gene assay for cystic fibrosis. So this is regarding the malnutrition. Regarding malabsorption, any cystic fibrosis with one of the following, including abdominal pain, cramping, bloating, flatus, chronic diarrhea, steatorrhea, fat-soluble vitamin deficiency, addict deficiency, especially for data of Prof. Hanan show that, or poor weight gain, think about malabsorption, mainly pancreatic exocrine insufficiency. So what is pancreatic exocrine deficiency? This is one of the most common malabsorption, account up to 85%. The pancreatic duct obstruction, it will lead to the acinar cells to replace the adipose tissues, and the pancreatic insufficient are more likely to have more severe lung disease, and they're more likely to have malnutrition, and more likely to have liver involvement. So those patients, they have decreased amylase, lipase, and colipase, and in addition to that, they will have increased production of salivary amylase with the brush border and equal lipase. In addition to that, those exocrine pancreatic insufficiency, they have decreased bicarb, which is the worsened enzyme deficiency and the enzyme optimal in alkalitic environment. So symptoms will be have foul smelling, and the diagnosis, you have many options. You may have fecal elastase or 72-hour fecal fat testing with clinical observation, but this test is difficult to format, and nowadays we didn't do it anymore. So because of the difficulties and because of the others like fecal chymotrypsin, fecal lipase, and secretin stimulating duodenal aspirate, all of these that are help. But the most important that we did it in our centers or in all other centers is the fecal elastase. One of the very high sensitivity and specificity up to 90–95% to diagnose pancreatic insufficiency, and the normal level up to 200. If you have the level 100 to 200, this is moderate or mild to moderate. If you have less than 100, this is severe pancreatic insufficiency. However, be careful because you may have false positive liquid stool, or if the child is aged less than 6 months, so fecal elastase will be inaccurate in these two situations. So the treatment of pancreatic insufficiency, usually we give pancreatic enzyme replacement therapies with extracting of the lipase and amylase, and usually it will be optimal dissolved in alkaline duodenal fluid, and the dose usually up to 2,000 units per kg per meal, and the parents will dose it according to the symptoms, including diarrhea, and later on you can assess for malabsorption. So what the dose? Usually in the infant, usually up to 2,000 to 400 unit lipase in 120 ml of formula. It comes with the powders. And in the children less than 4 years, usually I start up to 2,000 units per kg per meal. Or if you want to start by gram per fat, usually up to 4,000 unit lipase per gram per fat. So the message here, if you give lipase more than 2,500 units per kg per meal or more than 10,000 units per kg per day is not recommended. Why? Because it's associated with the colonic strictures or colonopathies, especially for children 12 years. So in my experience, I'm struggling always with the infant because usually the dose will be, first of all, the powder of the pancreatic enzymes is not available in all hospitals. And usually we ask from outside, and we have some difficulties how to put it in how much formula. But if the child more than 1 year, usually will be okay. So the complication, please remember, you have excessive dose, you have fibrosis and colonopathies, you may have colonic inflammation because it will irritate mucosa, and if the enzymes has prolonged contact with mucosa can cause ulcers. So this is why proton pump inhibitors has been valued. In contrast, if you have low doses less than 2,000, you will have growth failure. So this is why in a child with a cystic fibrosis and still not growing well, this is inadequate pancreatic enzymes until proven otherwise. And usually you may have fat or ADIC deficiency. So this is why it has been correlated the pancreatic enzymes in addition to the bone diseases, including calcium, vitamin D, and vitamin K. So in our practice, what are the factors affecting the efficacy? So if the child is an adequate dose, still has symptoms, still has diarrhea, not growing, so what are we going to do? First of all, we have to check about the storage of the enzymes. Is it exposure to the heat? And we have to make sure the child is not crushing the enzymes. When he's crushing the enzymes, will be useless. And usually, excess acidity of the gastric juice will have limit the efficacy. So sometimes you may do pH for gastroesophageal reflux. And in my practice, usually I do gastric empty studies or milk scan to make sure there is no slow gastric empty times. And the timing of the enzyme administration should be during meal, or sometimes I give at least 5 minutes after meals. And usually diet content is high or containing tomato-based food. So other cystic fibrosis that mimic cystic fibrosis that mimic pancreatic insufficiency. Sorry, it is small intestinal bacterial overgrowth. This causing malabsorption and creates susceptibilities, and usually the symptoms are non-specific, and the child presented with the bloating, diarrhea, weight loss, similar to pancreatic insufficiency. So the diagnosis here to do hydrogen breath test. It is non-invasive test. Usually you will see rapid increasing in exhaled hydrogen or methane after drinking glucose. And the gold standard diagnosis of small bacterial overgrowth, it is small intestine aspirate and fluid culture. And this is very invasive procedures. So the treatment is empirical cycle with the antibiotics, usually Ciptrin or Flagyl or any non-absorbable antibiotics. Usually I give 2 weeks on and 2 weeks off, 2 weeks on and 2 weeks off until to see symptoms improve. So very interesting. We published a child with have 3 diseases. He has cystic fibrosis, has celiac disease, and small bacterial overgrowth. So if you see the lecture of Dr. Prof. Hana, that celiac disease will associate with the cystic fibrosis, but the child is unlucky that they have small bowel bacterial overgrowth, and he responds to gluten-free diet and cycling antibiotics. So the message here, think about any cystic fibrosis or pancreatic insufficiency is not responding to pancreatic enzymes, search for celiac disease and small bowel bacterial overgrowth. Reflux, yes, is one of the risk factors for malnutrition because the child will have anorexic, and the mechanism of the increased incidence of the cystic fibrosis up to 30 to 40%. because of the higher intra-abdominal pressure from the cough or chronic cough. Those children, they have lower basal tone of lower esophageal sphincters, and they have effect of depressed diaphragm causing by lung hyperinflation, and some medication of the cystic fibrosis like theophylline or alpha agonist can reduce lower esophageal pressure. In our practice, usually I give empirical treatment. So I don't do endoscopy. I give high dose of PPI. I give up to 2 milligrams per kg per day, or reaching adult dose up to 40 milligrams. And this one, it will help the pancreatic enzymes activation as well as GERD for causing of malnutrition. And there is conflicting data about PPI. Is it increasing pulmonary infection and adverse effect on the bone health? And mainly, it is not still, this data are conflicting. So the next few slides is about nutrition and cystic fibrosis. And usually we ask our dietitian to optimize calories up to 2 times of the daily requirement. And our goal is to sustain weight gain. And some tips that the infant will give high calorie breast milk with the formula. For children and adults, we ask them to encourage take of the butter, margarine, adding oil, cheese, heavy cream, high calorie snacks, anything with the high calories. For protein, we ask our dietitian to increase the protein up to 2 times of the daily requirement. And usually it accounts up to 15 to 20% of the calories. For fats, usually we encourage that up to 40% of the calories, and hyperlipidemia and cystic fibrosis is not at risk. So we don't worry more for this. Regarding vitamins, usually I double ADEC or fat-soluble vitamins, fat-soluble vitamins, ADEC, and sometimes I add vitamins if required. Regarding sodium, because they have salt closing through the sweat, so we ask our dietitian to give up to 2 to 4 milli equivalent per day of the teaspoon added to the breast milk or formula. So for oral feeding, we usually ask them to take high energy oral intake. We ask them to have extra snacks. Usually we start ADEC as early as possible. We didn't wait to see if there's even the child is growing well. Usually I start empirical ADEC. Usually we ask for annual fecal elastase. Even if the normal, we can conclude that this is pancreatic sufficient, but he needs every year fecal elastase. Sodium supplementation is required, and urinary sodium creatinine ratio should be measured to assess how the sodium intake. Glucose tolerance test, we ask at the age of 10 years, and usually we refer to the endocrine for the glucose tolerance test, as well as bone densities to assess the bone status at the age of 8 years, and sometimes then zinc supplementation will be considered for nutritional status. If the oral feeding is ineffective, usually, or the BMI less than 19, I consider enteral feed. And you have many options, either NG tube or gastrostomy tube or nasojejunal tubes. But most of the time, or usually, they are nocturnal feeding. And we ask for high calorie dense formula, up to 1.5 calorie per ml, even up to 2 calorie per ml, like Scandi Shake and others. So we need to give high calorie formula. And the enzyme replacement should be before feeding or twice during nocturnal feeding, even though there is no clear for that. PERT did the nice studies that he found that the tube feeding affecting on nutrition and pulmonary outcome in cystic fibrosis. And if you see here, the BMI or z-scores for the cases after the index years is almost improving, as well as forced expiratory volumes with these lungs problems is being improved after the index years. So there is strong evidence that tube feeding has nutritional impact and pulmonary outcome. However, if you see the Cochrane review, 44 trials, all none for eligible of inclusion, and the enteral tube feeding is widely used throughout the world to improve nutritional and cystic fibrosis. And the most method they use it is nasogastric or gastrostomy tube, and they concluded they are very expensive and they have negative effect on the self-esteem and body image. So they conclude that enteral feeding suggests that it's result in nutrition and respiratory improvement, but the efficacy is not fully assessed by RCT trials. So unfortunately, we didn't have enough data for RCT trials to conclude that enteral feeding, it may help in cystic fibrosis. So what about appetite stimulant? Hominick did cross-sectional studies regarding periactin, one of the antihistamine called cyproheptadine, and he found that it is improving nutritional status by increasing the ideal body weight, by improving skin fold thickness, fat mass, and lean bodies. So sometimes I give it this one periactin if the child is more than 4 years, up to 4 milligrams, it may have effect for appetite stimulant. In contrast, there is RCT trials, pilot studies about megestrol acetate. Megestrol acetate, it is the hormone progesterone, and he found that has significant effect in weight gain in megestrol group comparing to placebo. They have significant change in the weight Z score. They have significant change in the high Z score, and even pulmonary function test and lean body fat. But megestrol has very serious side effects, including diabetes, including lungs problems, including malignancy. So nowadays it's not recommended, even they have nice studies, but it's not recommended anymore for megestrol. So in our practice, what if the patient is maximum dose and still symptomatic and not gaining weight? So in our practice, or I recommend to add acid blockers, give high dose proton pump inhibitors. Sometimes you may switch brand of the enzymes. So I'm sure there is 1 or 2 types of the pancreatic enzymes in Saudi Arabia. Make sure there is no adherence, and we have to make sure the enzyme is taken during the snack, and think about what other cause of loose stools, like celiac disease, like small bowel growth, and absolutely our pulmonologist will help us for controlling cystic fibrosis. And if you are struggling, refer to the pediatric gastroenterology for further workup. So cystic fibrosis nutrition counseling guidelines, we have to make sure that if the patient has aware about nutrition, weight, and pulmonary function, so we need to sit them, we need to explain to them that lungs is related to nutrition, and we need to check the calorie diet in diet. We have to make sure the dose, what about fat content, and if the patient has aware about to have boost calories, so we have to give him high calories, especially for high calories up to 2 calories per meals. Are the snack are available? So sometimes the children not taking the enzyme during the snack, and usually I recommend to give half dose. So for meal, usually up to 2,000 unit per kg per meal. In the snack, give 1,000 half dose. And we have to make sure if there are any psychosocial issues, which is very important, because the cystic fibrosis, the feeling that they are guilty, and if there is any stress at the meals, interfering with appetite, and most important, feeding and behavioral issues with the parent and the child, and if the vitamin are prescribed and the patient is taking well. Ladies and gentlemen, my conclusion is there is a role of nutrition in improving cystic fibrosis mortalities, and the early nutrition intervention has a vital role in the pulmonary health. And the risk of malnutrition and malabsorption, cystic fibrosis ranging between 10 to 20%, and because deficiency of pancreatic enzymes, and because of the bicarb deficiency and the lung inflammation of the lungs. Enteral tube feeding is widely used to improve nutrition in cystic fibrosis. You have many options, either nasogastric tube or gastrostomy tubes. Optimize calories and protein up to 2 times of the daily requirement to sustain weight gain. We should remember that pancreatic insufficiency is the most common malabsorption of cystic fibrosis, up to 85%, and growth failure and addict deficiency are due to low doses of the pancreatic enzyme replacement, while fibrosis colonopathy due to high dose of the pancreatic enzyme replacement. So anyone is interested in cystic fibrosis or nutrition, this is a nice reviews from the truck, that from the ESPEN and from the ESPIGAN guidelines on nutrition care for infant and children and adult with cystic fibrosis. At the end, I would like to thank, and I hope you enjoy my slides. Thank you very much.
Thank you very much, Dr. Hassousa, for an excellent presentation. We have, one question about compliance with both enteral feeding as well as pancreatic enzyme intake. Do we see compliance issues with patients? And how is it?
Of course, yes, good questions. Regarding the compliance, this is very important issues, and we have to address this one because most of the growth failure or patient with the persistent low fecal elastase because the child is not taking wells. So what our rules? Usually we ask to be seen by a social worker or health educator, a dietitian, and sometimes I refer to psychologist, not psychiatric, psychologist, to improve their awareness that pancreatic enzymes has been related to nutrition and pulmonary function aware.
Another question about diet. Would you recommend high-fat diet or MCT oil-based diet in infants, or add it to older children?
Yes, usually in the past they restricted about low fat because of they consider that the malabsorption, if you think about malabsorption of the fat, malabsorption of the carbohydrate, and malabsorption of the protein, they concern the child, they have more fat malabsorption. But nowadays, I don't restrict in the fat. They should have high fat, and even for MCT oils with up to 60%, yes, I recommend for that. So nowadays, no recommendation to restrict high fat diet because of the maintain his weight gain.
Okay, a third question about, do you change the sodium intake in summer, especially in hot areas?
Well, usually regarding the salt replacement, usually with collaboration with our pulmonologist. Usually our rules mainly for calories, protein, vitamins. For the salt, usually we didn't have good experience for that. So I cannot answer for the hot summer to replace it. But most of these children, especially the older children, they know that he's thirsty or not. So for the decision, usually based on our pulmonologist, and sometimes dietitian has been a rule to have replace of the sodium. But the main thing is to measure the urine creatinine sodium ratio to assess the sodium intake.
We just to mention that, some patients may present only with electrolyte disturbance. We have few number of patients, it's very low. You can count it on our fingers. They just present with hypokalemic, hypochloremic alkalosis, hyponatremic alkalosis, and they need just supplements. They sometimes need IV fluid to correct it, then they need supplements and it will be higher. If they are having problem with sodium, yes, you need to increase their sodium intake most of the time through their diet. طيب في سؤال ما ادري هذا مفروض الدكتوره بنجر لكن ممكن تجاوب عليها محمد. I want to ask question to how to prevent cystic fibrosis.
Well, the best thing is the screening. Someone he asked a neonatal screening. For neonatal screening, especially for the gene mutation, it will help for that because I remember data that if you pick up the diagnosis earlier, you will have good outcome. If you have diagnosis cystic fibrosis after 2 years, you will have bad morbidity and mortalities. So I think the best thing is the neonatal screening, increase awareness about cystic fibrosis and others, especially that Prof. Hana showed that it's up to 1 in 4,000 the prevalence. So I prefer that neonatal screening will be better.
In addition, any genetic disease nowadays, our colleagues in genetics and IVF, they use pre-gestational diagnosis and IVF. So these patients, if you determine their mutation, then you send them for IVF, and this is one way of preventing the disease. I think do you have, Dr. Lafer, any questions from the audience?
Raising his hand, Mr. Tawfiq Ata. You can unmute yourself and you can ask questions. Tawfiq Ata. Mr. Tawfiq? Okay, isn't it?
If we have no more question, I would like to thank Dr. Hassousa for his participation tonight with us. I know you are on leave now. You are enjoying your holiday in Abha, but you gave us this valuable time to join us in this webinar, and hopefully we will have you in the next webinars, inshallah.
It's my pleasure, Dr. Ali. It's my pleasure to participate in your event. Thank you.
Nowadays, it is my turn. I would talk about liver involvement in cystic fibrosis. And I will start with some polls. Please answer these questions. We'll give you 10 seconds. So liver involvement in individuals with cystic fibrosis occurs in 2 to 5%, 15 to 20%, 30 to 50%, 70 to 90%. Okay, maybe Dr. Banjar, she mentioned, something about it. So the majority, they said 15 to 20%, around 55%, and 35%, they think it is 3 to 5%. So this is just involvement of, liver involvement in patient with diagnosis of cystic fibrosis. Let us see the answer. So majority said 15 to 20%. Can we remove the polls? Yeah. Dr. Lafer, can you remove it, the polls? The result?
Yes.
Okay. So liver involvement in cystic fibrosis occurs in 30 to 50% of cystic fibrosis. And, 1/3 of you answered this. And only 5% of these patients will have CF-related cirrhosis. So only 5%. So others, they have different presentation. I will just take you through one of the patients that we encountered in our practice. A 10 years old presented with hematemesis. After stabilization in the emergency room, he was admitted to PICU for closer observation, and family denied any drug history or herbal medicine intake. Family history is negative for liver disease, and parents are first degree. This is the only child after IVF pregnancy. So which of the following physical findings indicates a liver disease in this child? Because, upper GI bleeding may be secondary to pheresis or liver disease, or secondary to ulcers or any vascular lesions. So if you think this is a liver disease, which one of these, let us see. We started good. So let us see, hyperpigmentation of the genitalia. It has nothing to do with hematemesis. If you have hyperpigmentation, then most likely you have, Addison disease or adrenal insufficiency. Cavernous hemangioma, this is against liver disease because the bleeding may be from hemangioma inside the gut. Abnormal ear auricles, it has nothing to do with upper GI bleeding. So if you have splenomegaly, then this is most likely a liver disease. It's either a portal hypertension caused by prehepatic, which is portal vein thrombosis, or hepatic, which is a liver disease, or post-hepatic, which is a hepatic vein occlusion. So the answer is splenomegaly. Okay. So when you examine this patient, he has a weight on the 5th centile and height on the 25th centile, and he has a splenomegaly of 7 centimeters below costal margin. So this is most likely liver disease. He underwent endoscopy and this finding of esophageal pharesis, and he underwent esophageal pharyngeal banding during the procedure. His labs showed, a WBC of 3.8, hemoglobin of 82, and platelet count of 53,000, which indicate pancytopenia. Most likely, this is secondary to hypersplenism. And his INR was borderline with slightly increased with 1.3, and albumin is on the lower side, which is 30 grams per liter. We worked him up for possible liver disease. Hepatitis B, C, EBV, CMV was negative. We worked him up for autoimmune diseases, and anti-nuclear antibody, anti-smooth muscle antibody, liver kidney macrosomal antibody was negative. Serum IgG is normal, which is increased in autoimmune disease. For Wilson disease, his ceruloplasmin was normal. We did a 24-hour urine for copper, pre and post penicillamine, and it was negative. So what is your next step? Would you do a liver biopsy, genetic testing, or no need for A and B at present? Don't do liver biopsy, don't do genetic testing. Okay, maybe we stop here. So the next step is some 45% they want to do a liver biopsy and genetic testing in 31%, and some they don't want to do anything. Okay, this is the liver biopsy, which is showing cirrhosis. It's very clear. So after that, would you consider doing sweat chloride tests? Yes, no, I don't know. Especially we are talking about cystic fibrosis in this webinar. So some will not do it. Sweat chloride test is a non-invasive test. And I think there is no reason why not to do it. It is just a simple test. If it is available in your center, you need to do it. So because cystic fibrosis can present with portal hypertension alone. The child has no lung disease, child has no malabsorption. And so the answer is majority, they said yes. Okay. So the sweat test was done 2 times and it was high. So we reach a diagnosis of cystic fibrosis. So this patient was diagnosed to have liver disease related cystic fibrosis. And subsequently we sent for genetic testing, which was showing a homozygous pathogenic variant in the CFTR gene. So this patient has cystic fibrosis. So involvement of the liver and bile ducts in cystic fibrosis can be clinically silent. These patients may not show up any symptoms and they present with just advanced cirrhosis. And cirrhosis may present with, ascites. They may present with upper GI bleeding secondary to esophageal pharesis. And the hepatobiliary complications of cystic fibrosis are increasingly recognized. As Dr. Hassousa mentioned, we are seeing more children who are living longer. Dr. Banjar mentioned also now the lifetime expectancy has improved compared to 30, 40 years back. So we are recognizing more patients with hepatobiliary complication. And liver disease is the third leading cause of death among CF patients. The first one is pulmonary complication. Second one, lung transplant complication. And third one is liver disease. And the pathophysiology of liver disease remains unclear. So advanced liver disease is primarily found in patients with pancreatic insufficiency. As you know, in cystic fibrosis, you have about 10% of patients, they have pancreatic sufficiency. They don't have malabsorption. However, those who have pancreatic insufficiency, they present with liver disease. As this child, his growth parameter was in the 5th centile. This may indicate an element of malabsorption and malnutrition. It was found that males and carriers of alpha-1 antitrypsin Z allele are at increased risk for advanced CF liver disease. To mention that, we don't have, alpha-1 antitrypsin in our area. Over the last 40 years, no single patient was diagnosed with alpha-1 antitrypsin, either lung disease in adults or liver disease in children. So this is found in the West. Alpha-1 antitrypsin Z allele increase the risk of advanced CF-related liver disease. And to date, there are no proven therapies to prevent development or progression of CF-related cirrhosis. The clinical picture of liver involvement in cystic fibrosis is shown in this table. Asymptomatic elevation of liver enzymes up to 35%. Hepatic steatosis up to 60%. Focal biliary cirrhosis up to 70%. Multilobular biliary cirrhosis 5 to 15%. And neonatal cholestasis is very rare to present, in cystic fibrosis. And gallbladder, they have cholelithiasis and cholecystitis, as well as micro gallbladder. When you examine these patients, you need to evaluate for stigmata of liver disease, including hepatosplenomegaly, ascites, Balmer erythema, spider nephi, jaundice, clubbing. And the biochemical evaluation include liver enzymes, including gamma GT, total bilirubin, albumin, and prothrombin time to assess the synthetic function of the liver, in addition to ammonia, cholesterol, and CBC. Screening for other causes of chronic liver disease, including autoimmune hepatitis, Wilson disease, viral hepatitis, alpha-1 antitrypsin, this is in the West, is highly recommended. So when you evaluate them from radiology point of view, ultrasound with Doppler to detect presence of radiologic cirrhosis, signs or complication of portal hypertension when you do Doppler, and gallstones. And endoscopy is used in patients presenting with upper GI bleeding, like our patient. However, it is not routinely recommended for all children with suspected CF liver disease. Liver biopsy is used to determine extent of fibrosis and to exclude other causes of liver disease. It is not routinely indicated. And the risk of and benefits of procedure should be carefully weighed. Our patient has a platelet of 53,000, so this is a risk of bleeding. So this patient was transfused during the procedure, and he was monitored closely in order to avoid complication of liver biopsy, which is mainly bleeding. In this study, they have compared ultrasound and biopsy in children with cystic fibrosis-related liver disease. And they, found that a significant association was found for the prediction of fibrosis or cirrhosis on the basis of ultrasound, if you have good ultrasonography. There was no significant association between normal or indeterminate ultrasound and the histology result. A high intra and inter-observer variability was found in sonographic assessment of the hepatic ecostructure. So if you have good radiologist, he or she may tell you, findings which is comparable to liver biopsy. And they mentioned that the role of liver biopsy for diagnosing liver disease and cystic fibrosis has been controversial in light of sampling tissue from a focal disease, because as we mentioned, it may cause focal cirrhosis. These concerns are not confined to CF, but broadly apply to liver disease, particularly those involving biliary disorders such as sclerosing cholangitis. If you have a focal lesion, if you do a biopsy, you may go to the normal tissue and you will lose the diagnosis. At present, liver biopsy remains the only test for assessing fibrosis, even with these acknowledged concern of sampling reliability. So when you screen for liver disease in cystic fibrosis patients, you need to do a careful examination by palpation, percussion of the liver and spleen size and texture at each visit. And the yearly panel of liver blood tests should be performed on all CF patients. And these are the recommended yearly laboratory tests in these patients, as we showed earlier. And in management, you need to have a multidisciplinary approach, which is very important. You need to have a hepatologist, pulmonologist, surgeon who have experience in hepatobiliary surgery, radiologist, and very important part of the team is a dietitian. The role of dietitian is extremely important, as was mentioned by Dr. Hassousa earlier. If you have a hepatic steatosis, you need to optimize nutritional status of these patients and consider evaluation for deficiencies of essential fatty acids and evaluate for possibility of diabetes mellitus in these patients. And some of them, they may develop diabetes in the future. If you have cholestasis, fibrosis, or cirrhosis, then the goal of therapy is to limit ongoing injury to the liver, prevent complications such as fat-soluble vitamin deficiency, and manage the complication of portal hypertension. No therapy is yet known to alter the progression of CF liver disease. If you have gallstone, if the patient has clinical symptoms, or he has abnormal blood tests, I mean, they have high gamma GT, high alkaline phosphatase, and high bilirubin, which may indicate common bile duct obstruction, then laparoscopic or surgical cholecystectomy should be performed unless end-stage liver disease is present. And at the same time, during the laparoscopy, it is recommended to do a liver biopsy and intraoperative cholangiogram in these patients. Nutritional therapy is based on medium-chain triglyceride-based formula in infants, monitoring of fat-soluble vitamin levels every 6 to 12 months. And as mentioned earlier, cystic fibrosis patients require high doses of vitamin A, D, E, and K to obtain optimal serum level. And it is not enough. It was mentioned very clearly in our patients by Professor Banjar that they have vitamin deficiency still with supplements. So the need to double the doses is justified. A 12-year-old boy with cystic fibrosis has 2 episodes of upper GI bleeding. True statement is, this is a question just to stimulate, the management in these patients. لا في السؤال قبل أيوة. لا في السؤال قبل دكتور ظافر. وإلا ما هو موجود. دكتور ظافر تسمعني؟ أيوة. Good. So you start propranolol ولا serial pharyngeal binding ولا transfers TIBS ولا referral for liver transplantation if a patient has 2 episodes of upper GI. So let us see. So the percentage is changing very rapid. Almost 30% for the first 3 and 10% for the last option. So propranolol, pharyngeal banding, TIBS, and let us see in the next slide. So if you have a bleeding varices, and then you deal with it as you deal with other patients who have varices. Stabilize the patient, and then you do endoscopic treatment. And beta blocker therapy should be used cautiously in those patients with asthma or other airway hyperreactivity syndrome. As you know, beta blockers may exaggerate asthma. exaggerate, obstructive lung disease in these patients. So we need to be cautious. So propranolol may not be used in patient who has bad lung disease. TIBS is left for patients who are not responding to medical treatment. So you send them for transvenous intrahepatic portosystemic shunt as a bridge for liver transplantation. And for the transplant, we will discuss it in the next slide. So if you have ascites, then you need to restrict salt, use diuretic therapy, and if refractory and causing respiratory symptoms, then you may need to go for paracentesis. And TIBS also is indicated in patient who has a refractory upper GI bleeding and who has refractory ascites not responsive to medical management. If you have hepatic encephalopathy, then you restrict protein intake, start lactulose, use oral antibiotics. And if you have spontaneous bacterial peritonitis, then you use systemic antibiotics once blood and acidic fluid cultures have been obtained. So liver failure is rare in cystic fibrosis patients. And when it occurs, usually it occurs late in the course of the disease. And liver transplantation should be considered, especially if pulmonary function is well preserved. So if you have a child who has pulmonary hypertension, then referral to experienced liver transplant center when there is evidence of decompensated cirrhosis, difficult to control ascites, prolonged prothrombin time, unresponsive to vitamin K, hyperammonemia, or encephalopathy. And in this paper from Birmingham, they have reviewed their experience with transplantation for cystic fibrosis, and they have 24 patients, 15 adults, and 9 children. And these patients have either single liver transplant or triple transplant with heart, lung, and liver. And they concluded that liver transplantation is effective therapy in young patients with cystic fibrosis, portal hypertension, and hepatic dysfunction, and indicated before a critical stage of deteriorating lung function is reached. In patients with both end-stage liver and lung disease, triple transplant has a poor prognosis. Preemptive liver transplant in younger patients with cystic fibrosis not only has a better outcome, but improve lung function. So if you have a child who has decompensated liver, you need to send them for transplant since lung function is good. What about treatment? Traditionally, we use also deoxycholic acid in patients with cystic fibrosis in attempt to delay the progression of cystic fibrosis liver disease. Is this true or false, or I don't know? Okay, I think we need to stop here for the sake of time. So like 50% they say true, 26% they say false, and 24% they say I don't know. So if you talk to people about orso, yes, they think it is indicated. So the majority answered, yes, it is indicated. However, in this Cochrane, publication about the use of orso deoxycholic acid for cystic fibrosis-related liver disease, which was published in 2017, and the authors are from UK. They have reviewed the different 12 trials in this matter, and they have concluded insufficient evidence to support routine use of orso deoxycholic in patients with cystic fibrosis. So most of that practice now is not, based on a scientific, basis. So further randomized controlled studies are needed to assess the safety and efficacy of orso deoxycholic acid in cystic fibrosis liver disease. So is it good? Some people, they just use it, and they have mentioned that although orso deoxycholic acid is a cheap drug, however, they will, direct the money used for orso to other aspects of care to these patients. And what is the implication for practice in this study? They said, although also the oxalic acid is relatively inexpensive compared to other CF treatments, it would need to be taken on a long-term basis if it is effective. If it is ineffective, then the resources saved by not using it could be used for other aspects of CF care. So the evidence of the effectiveness of also deoxycholic acid is inconclusive. Routine use in patients with CF cannot be justified. However, in view of these important preliminary results and because of the lack of any other effective intervention to prevent or treat CF-related liver disease, it is essential that a large multicenter random controlled trials of orso in people with CF is undertaken. And in this, article, I recommend people to treat, to read this review, which was published in November 2020 about the current treatment option for cystic fibrosis. And they are, talking about CFTR modulators, which has been, tested in patients with lung disease. However, none have been, used in patients with, cystic fibrosis related liver disease. What about Saudi Arabia? This is the only publication about the Saudi experience, although Dr. Banjar, she has mentioned her data, which is not published yet about the liver disease and cystic fibrosis. But in this, presentation by Dr. Hisham Nader and Zuhair Rahbini, they have, reported 36 cases. That was long time ago, between 86 and 92. And they have 9 patients were originally referred because of having other disorders, but subsequent investigation confirmed the diagnosis of cystic fibrosis. The referral diagnosis, number of patients were jaundice for investigation in 4, glycogen storage disease in 3, hepatomegaly for investigation in 1, and neonatal hepatitis in 1. So still, people, they are not aware about the existence of cystic fibrosis liver disease, which may present isolated. You don't need to have lung disease or intestinal disease or, frank, pancreatic insufficiency. By this, I need to conclude, and thank you very much for your listening, and we will be happy to have your questions.
Thank you so much, Dr. Ali. Thank you so much for this nice presentation. There is one question, if you allow me to read it. CF patient with asymptomatic gallbladder stone by ultrasound with normal LFT. What is the role of orthodeoxycholic acid and how long it be continued? If stone size is static, shall we stop it or not?
As was mentioned earlier, there is no, clear data about the effectiveness of orthodeoxycholic acid in cystic fibrosis patients, whether they have stones or they don't have stones. So, from this Cochrane study, there is no rule for orthodeoxycholic acid in cystic fibrosis patients, either for prevention or for treatment.
Excellent. Thank you so much. There is also another question. Have you ever seen neonatal liver failure with CF, as we have a case of genetically confirmed CF? We think neonatal liver failure is still not explained by CF. What do you think, Dr. Ali?
I haven't seen any patient with neonatal liver failure diagnosed to have cystic fibrosis. We have seen a few patients counted in fingers who has cholestasis. However, we did not have that. But however, if you have a confirmed diagnosis of cystic fibrosis, then this is maybe a good case report, which could happen. Everything could happen now with genetic testing. Now we are discovering, a lot of, facts which was not there before. And we have disproved some facts, which was facts for many years, 50 years, 100 years. This disease cannot present like this or present like this. And when we have this genetic era now, then we learned a lot from the genetic diagnosis.
Thank you so much, Dr. Ali, for this nice answering the questions. Please, if you would like to finish, I think there is no more questions. Some of the questions already answered through your talk. If you want to close this session, and thank you so much.
Thank you, Dr. Dhafir, for your technical support as usual. And I would like to take this opportunity to thank our speakers, Professor Hana Banjar, who talked about the status of cystic fibrosis in Saudi Arabia, and Dr. Muhammad Hassousa, who talked about the malabsorption, malnutrition, and cystic fibrosis. And it's very important. These our social media accounts. If you are interested to follow them on Twitter and etc. So please feel free. And this meeting is recorded, and you can go back to it if you like in our Twitter and in our YouTube channel. And I would like to invite you for our second webinar of this single topic series, which will be on 6th of July, where we will talk about metabolic liver disease. We have eminent speakers also. At that time, it will be announced shortly. However, we are now discussing more interesting topics which have been not discussed before. So we are concentrating on these issues, which is common now in our country, and we are seeing more and more patients with these diagnoses. I would like to thank everybody for their attendance and participation, and I hope you have enjoyed the 3 talks. Thank you very much, and hopefully we'll see you soon.
Thank you, Dr. Ali. Thank you so much. Thank you for all.